So we are using EBO currently within NELFT to manage our appointment flow, and we've seen really from our side of things that unless we have a PHR or a PEP that fully engages within our EPR and fully integrates, then the patient journey isn't seamless, and it generally brings a lot of overheads to a trust to try and manage and to oversee. So not necessarily around the efficiencies you gain from clinical or admin workforce, but just really around the ability to share information in real time, the ability to communicate with our workforce and communicate with our patient cohorts in real time, changes to appointments, changes to locations, updates to documents, etc. Really for us, that's been our biggest overhead really, and our biggest lessons learned since going live with our PHR in North East London. And it's sort of at this moment in time made engagement quite difficult as well on the clinical side, because unless we can get into a position whereby our product is seamless and works directly into the EPR, so that clinicians don't feel that it's a burden in terms of having to manage a separate set of notifications and having to manage separate dialogue with patients, we felt like the clinical engagement at this moment in time is just too much for us really, with all the pressures to the NHS, pressures to workforce, etc. Giving them a tool that is an addition to what they currently do has been a bit of a hurdle for us to overcome. So I'd say that's probably our biggest lesson learned so far. The other thing I think also which we picked up is just around data quality and practice. So just making sure that you're changing cultures and ensuring that we're recording the appropriate appointment times, letters are uploaded to the right document types, and the correspondence that you're happy to share with patients is accurate. So there's obviously a data quality piece there as well, which again, having direct integration would help us with, I think, in that side. Samir, from a clinical side?
So for me, these patient portals really come down to what patients are asking for, and it's about trust as well. So one of the things that they're asking for is we don't want to repeat our story. We don't want to do things again and again. And it's also about being able to communicate with them. The things that are really exciting sort of for me as somebody who's working as a clinician most days, is that we can start bringing in structured data from lots of places and start having some sort of way of saying, look, these people are higher risk, because we don't know anything about people when they first get referred really. These people are higher risk. Can we do something to help that person and get them ready to be seen by someone super specialist? So example, I'm a old age psychiatrist. I run a memory service, and for example, we're working on something that identifies people who are taking high risk drugs, so they'll be seen by a pharmacist before we even touch them. Another example might be that you run a chest clinic. You take you take data from a different source. You see what their compliance with medication is, and then do an interaction before they get seen by a secondary or tertiary specialist. So it's about taking data from lots of different places, having that level of trust with people, being able to make really basic decisions. So you might have a waiting list, but you're actually using that waiting list to give people a better interaction later on. And if you're reducing drugs and optimizing drugs early, you actually have much better long-term outcomes. So that's what I'm really interested in, and that kind of accessibility and that kind of trust.